Good afternoon. On behalf of the HTAS, welcome to everyone and thank you for joining us today. This is the second webinar organized in response to the COVID-19 pandemic crisis. I'm Pranveer Singh. I'm a consultant psychiatrist working in Essex in a CRHT and also chair for the HTAS advisory group. The purpose of the seminar is to provide discussions and examples of how CRHT services are adapting and responding to current coronavirus epidemic. Needless to say that CRHT services are central to acute mental health care pathway. They play a vital role by providing an alternative to hospital admission. Typically, people who are acutely unwell receive intensive treatment at home, and now there is possibly a far more greater need for home treatment than it has been before in usual circumstances. As a result of impact of coronavirus crisis, it continues to be a very difficult time for our patients with acute and urgent mental health needs. The situation is incredibly complex and is changing often and face huge amount of uncertainty. Therefore, it has become potentially challenging for us to continue with the standard ways of working. Assessment and treatment provisions from crisis services can be a challenge to continue with. The way we provide home treatment, gatekeeping, working with other teams and facilitating early discharge can be affected. Such deviation from standard way of working can have an overall impact on the care of patients and also on the entire acute care pathway. The webinar has been put together today by the members of the HTAS advisory group and speakers, experts in their respective areas. I'm going to introduce my co-speakers shortly as we go through the webinar, and we would be speaking about how we are approaching the main areas of CRHT functions which have been affected. The live questions can be posted via the text box. The panelists would try to respond to any questions, and in case we are unable to respond directly, we would get back to you. The webinar would also be recorded and posted on the CCQI web page section on the RC Psych website for people to access afterwards. I would now introduce Sean Boyle, who is a clinical director from Cheshire and Wirral NHS Partnership Trust. He is today with Jane Tyler, and they would be speaking about how they are responding to service delivery, assessment, and gatekeeping in the services.
Pranveer, I think Sean's having difficulty with his audio.
It appears Sean is having some difficulties with his audio, I've been told. So I would move on to the next session. We'll come back to Sean when Sean is able to join us. And I would move on to the next session about team working, home treatment delivery, to be run by Georgina Mills, who is a clinical lead in Southwest Essex CRHT and also a member of HTAS advisory group.
Hi, thanks for the introduction, Pranveer. So next slide, please, Cassie. So as you're all very much aware, multidisciplinary work is very central to the success of the home treatment team interventions, and this is something that we're working really hard to ensure continues during the COVID outbreak. So my team, which is based in South West Essex, we've been continuing to have face-to-face handovers and MDT, but we put meetings daily, but we have put measures in place to ensure the safety of staff during these meetings. So these meetings are now taking place in a very much larger room to ensure that the team are able to adhere to social distancing guidelines and for their safety. So when 40 MDTs is not able to convene together, this may be due to some of the staff shielding or working from home. We have been using Microsoft Teams so that staff can link into the meetings remotely to enable them to contribute to the discussions and the decision making. So we have given further consideration to the possibility of the MDT meetings having to take place with all staff working remotely, should this be necessary. And we have ensured that all staff are set up with Microsoft Teams, so we have this option if needed. As this is something that staff in the team aren't used to and they're not very familiar with, we've been doing some sort of in-house training sessions to ensure that everyone's familiarised with this way of working, should they be required to work from home or to be isolated. As discussed, we've put quite a few measures in place to ensure that the team can still continue to function should the COVID outbreak limit movements further. However, we've not fully implemented this at this stage, as we have felt that it might impact on the quality of information being communicated during these meetings and maybe the richness of the sort of MDT discussions, but we're all set up and ready to work from that way if necessary. So we put some planning in place with that. So we've also set up a working group within the 3 home treatment teams in our STP, and we've been having weekly teleconferences to discuss any changes to practice, discuss any issues and troubleshoot. And this has been a great way of sharing sort of good practices and working through some issues to set up new ways of working at this time. So in the current climate, this way of working is working for us as a team. However, we are continuing to explore different methods of conducting meetings should circumstances change in order to continue to effectively run as a team. Cassie, to the next slide. So to ensure that we continue to provide the best service, we have put various practices in place to ensure the safety of staff and patients. So in relation to the office and working environment, we've introduced sort of additional cleaning schedules. We do have domestics come in and clean the areas once daily. However, they're not able to provide any more than this at this time. So we have taken this on as a team, just sort of ensuring that everyone's cleaning their workstations and any other areas. We've also implemented sort of social distancing at the work desks and the workstation to ensure that staff are sitting more than 2 metres apart at all times, and everyone has their own allocated laptops and equipment, so there's no issues with sort of sharing of equipment. We have now all staffs have now been issued with a set of scrubs along with the necessary PPE equipment that they are required to go onto any of the wards should they need to go onto the wards. But we are also limiting our movement onto any of the inpatient and assessment wards, and whenever possible we're attending via video link. Personal protective equipment is being used for all of the visits in the community. The PPE is distributed from a central supplier within the trust, and to date we haven't had any issues with getting the necessary equipment. However, we do have a clear sort of escalation route of how we can escalate that if we have any issues with getting supply, and there's a 3 times weekly sort of audit of PPE that is being doing in all areas of the trust to ensure that everyone has and can maintain adequate supply. So prior to any home visits taking place, we are completing a screening questionnaire with the patients to establish if they do have any symptoms of COVID-19 to ensure that safe working practices for the staff and the patient for that visit to go ahead. And this is then repeated at every contact with the patient so that we are monitoring that status. So as a team, we're risk assessing all of the home visits and trying to minimise our movements in the community. So over the past few weeks, our trust has approved use of Accreditation, which is a video calling and messaging service for use with patients. I can only speak about my experience of this specific programme. However, it's been really easy to use and really well received amongst the clinicians and patients as well. Decisions to home visit or video calls are made during our MDT and handover meetings, and there have been occasions where video calls have taken place, and then due to the concerns and risks, they have then further been escalated to a home visit, sort of a face-to-face contact, so that option is always there. The majority of our initial assessments are being done face-to-face still, but we have had occasions where they are being done over video calling, but again, anything face-to-face is all risk assessed first, and the appropriate PPE is used for that. So within our service, the standard practice for transferring a patient from our team onto another team is via a joint face-to-face review. However, we have sort of adapted that during this time, and we're not doing those face-to-face handover meetings. We are doing them more remotely with video link up, and again, to minimise the amount of people meeting in one place and minimise the risk of COVID. So that's it for me at the moment. I'll be happy to answer any questions a bit later on if anyone has any. Thank you.
Thank you, Georgina. I'm going to speak about risk management and leadership in CRHTs, and these are very important areas enabling us to run our services safely and effectively. We all know that even at usual times, risk management is a key component of care delivery in crisis teams. Our teams are also main setting for suicide prevention. With the pandemic now, it is likely to bring challenges in our ability to manage the risk due to various rapid service changes and unexpected causes. Broadly, risks to our patients in CRHTs can arise from the nature of patients' mental health disorder, psychological distress, psychosocial circumstances, and the challenges in pathways and care delivery issues. Overall, I think the starting point is that in light of the pandemic, we must ensure that risk to our patients is addressed and patients receive safe and effective care. To do so, Cassie, can I have the next slide, please? Firstly, within our services, we should aim to ensure that access into our services and pathways out of our services are clear and agreed, so that there remains a provision of good information sharing while taking on patients for home treatment and while while transferring patients to other services, as Georgina mentioned just a moment ago. This can be in the form of telephone discussions or video handovers or joint visits if necessary. From a wider perspective, we must ensure that risk management is one part of the whole system approach, which in addition to CRHT is likely to be affected by the pandemic. Quality of home treatment is also very important, and it affects the patient's risk and is directly related to that. To ensure that quality of home treatment remains patient and carer centered, there is a need to continue to undertake the home treatment sessions with the similar frequency and the quality as we would have in normal circumstances as far as possible. It is likely that this ability will be affected. We may not be able to see our patients as much as we would like via face-to-face contacts. However, this can now either be carried out remotely, and in some cases we may still have to see them. As part of our home treatment sessions, we should continue to ensure that during such consultations, the emphasis should remain on building relationships with patients and carers, gathering good quality information. As we do in face-to-face contacts, we should continue to explore the current situation, past history, social factors to inform a collaborative approach to risk management. Over the video consultation, we should be comfortable, and we are. I think I have been doing video consultations asking patients and carers about suicidal thoughts. Most likely, when we are using remote consultations, we must strive to make use of them as far as possible so that good risk assessment continues to take place. There are a number of guidances around the use of remote consultation, and one of them is available on the college website. And obviously, I mean, needless to say, when it is not possible to undertake a full risk assessment over the video, there would be a need to undertake a face-to-face assessment, and then it may be useful to discuss that challenge in the MDT or make a clinical judgment based on the presentation you have in front of you. We need to ensure that we continue to share information timely with all those involved in the care. Can I have the next slide, please? The pandemic is an ultimate clinical leadership challenge. It is placing huge pressures on the ability of the CRHTs to deliver safe, high quality care. This means that senior clinicians in the teams would need to prioritize their focus on meeting the core patient needs, be able to engage in risk management, decision-making process, and core needs of staff, while ensuring that the staff well-being and sustained motivation is there to help them deal with this rapidly changing situation. It is important for the senior clinicians and the team leaders to be able to manage, to be able to adapt the leadership styles to rapidly changing situation. Very important that staff is supported. It is distributive, and compassionate leadership would be the most potent way we can deal with what feels frightening and overwhelming. And we need to ensure that we have safe staffing levels and ask for help when necessary. And to conclude with two important messages on this issue, it is very important, I think, to share information, guidance, which is being distributed locally and is being developed nationally within the teams. We need to tell the staff what we know, we don't know, and that we will get back to them to discuss what they are not aware at the moment. And finally, we need to stay focused on that we are going to continue to provide the best attainable care for our patients, and we are going to do the best as we can. I would come back with any if there would be any questions at the end, and would now pass on to Dr. Bakshi, who is a Deputy Medical Director in Norfolk and chair of a chair of an ethics committee, to speak about the medical legal considerations.
Thanks for the introduction, Pranveer. Thanks, Pranveer. As you said, during this coronavirus pandemic, I have been tasked with chairing a clinical and ethical advisory group for our trust. The coronavirus is an unprecedented pandemic. It is a situation so unique that I can safely say that none of us have experienced anything like this in our lifetimes. As the pandemic evolves, we are seeing, and we will continue to see, departures from established procedures and protocols. Now, departure from established procedures is not something which sits comfortably with any of us. As doctors, as professionals, we are trained to practice evidence-based medicines. So no wonder we are a bit confused and dazed, because this is clearly an uncharted territory. However, we need to remember that there are departures from established practices. There are no departures from established principles. We have robust ethical and clinical principles to assist us in decision making. We have the good medical practice, which provides us a framework for ethical decision making in a wide range of situations. This pandemic, more than any other crisis, calls upon us to use a clinical and professional judgment to apply those ethical principles in the situation which we face. I won't go into the good medical practice, but I would like to mention a couple of points which are of particular relevance to acute services, the crisis services. One of them is the principle of equality and equity. We care for patients who are vulnerable on account of their mental illness. In particularly, the crisis team is caring for people who are severely unwell and might have their capacity impaired or their judgment impaired. We are aware that the group of patients which we treat have much more physical comorbidity than the general population. We are also aware that people we treat are less likely to seek help for physical health ailments. And unfortunately, we are also aware that the patient group which we treat is also discriminated in accessing.
Sean Boyle, Jane Tyler.
Is now exiting.
There's some degree of discrimination in them accessing help on account of their mental illness. So during this pandemic, it is of crucial importance to us that we ensure that our patients receive good medical care, treatment and advice, not just for their mental health, but also in relation to the coronavirus pandemic. It is also important that we do not discriminate ourselves. The presence or absence of COVID-19 should not be a limiting factor in making treatment decisions. Treating everyone equally doesn't mean that we should be treating everyone similarly. Each individual will have a different risk profile. Each individual will have different considerations and needs, and we should be mindful of those needs. The COVID suspicion or positive test of COVID-19 adds another dimension to our risk assessment and management. During a pandemic, it is also
Sean Boyle, Jane Tyler.
During the pandemic, there is also an ethical obligation on all of us to minimize the spread and the harm caused by the pandemic. We have already talked about certain practices which have evolved to do so. One of the practices which has rapidly taken hold is remote consultations and virtual consultations. Now, remote and virtual consultations are not without their own problems. As psychiatrists, we rely quite heavily on our senses. We rely on patient appearance, their behavior, subtle physical signs. We rely on emotional psychological processes like transference and counter-transference. And remote and virtual consultations do not capture the full picture. So it is important to be mindful that they are not a replacement for a face-to-face consultation. They are an aid in this difficult times, and it is one of the tools to help us make decisions about patient care. Pranveer already mentioned that there is a very good guidance available on the college website. It has some practical tips on how to get the best out of remote consultations. I'd also like to mention the information governance around the consultations and the different programs that are being used. Georgina mentioned a program in my organization. Another program is being used. It's called Attend Anywhere. It is important that people use approved platforms to do video consultations, because there are concerns about patient confidentiality during these processes. NHS Digital also has very good guidance on maintaining patient confidentiality. There are practical tips like checking the identity of the patient. There are practical tips like not to be in a public place when you are doing the consultation, ensuring that the patient is not in a public place, getting a clear idea of who is available in the room. So there are practical tips. I won't go into detail, but I would suggest that people do read guidance around the information governance. Secondly, I talked of the principle of equity of access. It is also important that we are mindful that not everyone or not all of our patients are able to participate or engage in video consultations. I cover a large rural area where internet access is quite patchy. So not everyone will have access to those. Equally, I don't want to stereotype, but people have different levels of technological literacy. So it might be necessary that rather than video consultation, a telephone consultation might be more appropriate. Overall, I would say that there needs to be some discussion with the patient, with the carers, the care coordinators, or people who know best to see what would be the appropriate form of consultation. I'm also aware that in some organizations I have heard, I don't know how much of it is true, that mental health act assessments have also happened virtually. So far, we have not got any guidance on it. And I'm aware, or I've been told that later on this week or early next week, NHS England will be issuing some guidance on virtual consultations for Mental Health Act purposes. I think the general feeling is that it will be recommended in exceptional circumstances only. There could be different situations pertaining to Mental Health Act which are more easier to do virtually, such as converting a Section 2 to Section 3. It might be possible if you have full knowledge of patients that it could be done through a virtual consultation. We don't know. As yet, there's no clear guidance and none of these have been tested in court. We also need to remember that even during a pandemic, the accountability still holds. So whatever decisions we are making or whatever departure from practices we are making, we need to ensure that they have sound clinical reasoning, they're based on ethical principles, they are based on NHS values and our own professional values. Documentation is of key importance there. It is even more important in these situations. I would suggest that not only we document our decisions, we need to document key considerations and we need to document the rationale for the decision as well. Our regulators, GMC, CQC, NHS England have assured us that should any of those decisions be called into question at a later date, it will be judged according to the facts available at the time and not with the benefit of hindsight. This is a quite an important statement. So we need to ensure that the facts available, the considerations we had in decision making are properly documented. The situation is rapidly changing. The information is arising quite rapidly. So if certain facts change or the circumstances change, we should be flexible and responsive enough to review our decisions, to revisit them and revise them as necessary. During this pandemic, there are a number of support mechanisms available to help with decision making. Georgina mentioned that MDT is an important process. It's not just safety in numbers, it is to understand different perspectives, to engage with different stakeholders, and it increases the depth of decision making. There are already established professional processes such as peer group. I know these have fallen by the wayside because everyone is busy in a crisis, but I would urge people to seek help for the peer group to ensure that the decisions are robust. The college is regularly publishing guidance. The college has hub and has formed networks to share practices across the country. The GMC also has an ethical hub where you can post your concerns and queries and share practices as well. Most trusts I'm aware of have formed ethical committees. They have different names. They are usually led by medical directors or deputy medical directors like me. We don't comment on individual cases, but where there is policy matters or changes in procedures which have an impact on the team and services, we are able to offer recommendations. I think people should not feel unsupported in this thing, and the college is playing quite an important role. The GMCs, the defense unions are regularly issuing guidance on what could be, given the circumstances, be considered as reasonable clinically and ethically. I'll stop at that, and I'm happy to take any questions, and either now or towards the end of the webinar.
Hello. Hi, Cassie. Hi, Pranveer. Thanks for the opportunity to talk today. My name is Luke Sullivan. I'm a clinical psychologist with the Lambeth Home Treatment Team. And we're here to talk to you today about a guide that we've put together. Cassie, could you show the first slide? Called the Coping in Crisis Coronavirus Survival Guide. This was something that we thought would be really helpful for everybody right now, that we are all, by definition, in a crisis, and therefore myself and Gabriella, who will be talking you through the guide shortly, thought that the model that we use in the home treatment team for working with people in suicidal crises had relevance sort of outside of that setting. So we've taken the model that we work with in Lambeth, the psychological model for intervening with people in crisis, suicidal crises, and we've tried to take all of the content from that model and put it into a guide whereby we have tried our best to do something that's easily understandable, taking all the principles, the techniques, the tools, the evidence-based practices that we use in home treatment teams, and making it relevant to all people in the general public, and also to our staff, and also to our service users. The guides are available via Men's Minds Matter, which is a community interest company both Gabriella and I run, and we'll talk you through the guide and then we'll show you where it's available at the end. So I'll hand you over to Gabriella now.
Hi everyone, can you hear me? Great. So thanks, Luke. So
yes,
yeah, so
we can hear you.
In times of crisis, yeah, so in any sort of crisis, including this pandemic, there are typically and broadly two states that people can present with an experience, and they may stay predominantly in one mode or move between them. The first being threat activated. So here it's very much focused on the problem, and we see sort of strong emotions that might include anxiety, anger, feeling trapped. And on the other side is more depressive states where people can shut down as a way to protect themselves from getting overwhelmed. We see flatter affect and a sense of defeat. And there are risks on both sides, as well as effective coping strategies to help move from an extreme position to a more balanced and safe place. And the aim is to help people get to the best place psychologically so that they can get through challenging times safely. And so first wanting to talk about managing difficult, strong emotions, and then managing isolation and withdrawal. Great, thanks. Next slide, please. Okay, so yeah, firstly, I think an acceptance and acknowledgement that some level of anxiety is normal now. So COVID represents a threat, and we're experiencing an extreme situation never really seen in modern times in terms of the measures that are being put in place. And also that anxiety is needed. It's our internal alarm bell that helps us to put plans in place to stay safe. But it's only useful up until a point. And the way that the threat system works is that, you know, people will experience the uncomfortable emotions that direct thinking and behavior to solve a problem in a crisis. And while this might work well for immediate threats seen in fight or flight, the threats that are outside of our control, like the coronavirus pandemic or things that lay ahead that we might try and preempt, it can lead to anxiety that is more than it needs to be. And this can create problems like overthinking, sleep issues, difficulty problem solving, and emotional distress. So as in any crisis, including this one, there are likely to be legitimate threats and dangers, and number one priority is to make things as safe as they can be and address these. So this can involve assessing individuals' level of risk in relation to the virus, financial situation, living situation, and then putting plans in place, which may include following guidance from government and services and reaching out for practical help if needed. And once a plan is in place, anxiety has really served its initial purpose, and threat-based emotions for most people should reduce, and attention and time should be directed to other things that do not focus on the problem. And of course, if focus does remain on coronavirus, and anxiety and emotions may remain high, and this can become really intolerable for people. So there are techniques that can be used to help reduce the sense of threat and switch on the body's safety system. And we've included some of these techniques here that we use within Lambeth Home Treatment Team, and the guide goes into a little bit more depth about what each of these involve. But they're all about helping people manage strong feelings so that they're able to function and find safety. Next slide, please. Great, so moving on to the next mode that I spoke about. So most people were all being asked to stay at home, and this can present many challenges, including losing normal ways of coping, like keeping very busy or routines in place. And isolation and withdrawal are linked with depression, because as people start to do less, they create more space for problem-focused thought and less opportunity to experience pleasure or a sense of achievement. And so the first thing to focus on ourselves and to help other people focus on is establishing a routine that ensures getting the basic things right. So as the pandemic develops, initial anxiety may develop into more depressive states. And if people are feeling low, they may stop doing things they usually enjoy, including the basic things. And the triangle I put here, called the hierarchy of needs, can be helpful to demonstrate the importance of caring for fundamental physiological needs and establishing safety, from which we'll find it easier to connect with others and feel good about ourselves. So in practice, this really means establishing a good baseline routine involving sleep, food, water, movement, contact with the outside world. And secondly, it's really important to remain connected with activity, experience, and people. And this will help address the withdrawal and isolation linked with depressed mood that I mentioned. It provides less time for problem-focused thoughts and more opportunity to experience pleasure. And this definitely isn't about kind of encouraging people to do lots. We need to get comfortable with doing less, but it's about structuring the day so that basic needs are prioritized, then identifying small and achievable activities that are meaningful in some way. And at this time, there are lots of free resources online that can help people identify things to do. And we've included some of these in our full guide, which there's a link to at the end. If you go to...
Yeah, thanks, Gabriella. Just to mention on this slide here, I think it's really important to recognise that we are all trying to work in a crisis. We're not at home on holiday. This is something that affects us all below the blue line. So within our home treatment teams, within crisis resolution home treatment teams, I'm yet to find anybody that isn't affected below the blue line. And everybody that we work with, they really do struggle to get the basics right. Actually, people stop eating, they do stop getting up, they do stop washing and looking after their self-care, they do stop leaving the house, they do stop moving, and all of these things, as Gabriella says, creates that space in which this problem-focused thinking can take over. So the way that we see it in the home treatment team is that we need people to really understand that there's a minimum level of functioning that we always need to maintain and sustain in order to prevent ourselves from slipping into those depressive states. Protective about slipping into depression. It's also about really being fair and aware that we're not able to function to our full potential. And that can be really quite frustrating for a lot of people. So really recognizing that this has an effect on all of us. It's not just our patients, but it's the staff, and it's all of us as the general public. And all of these techniques and tools are relevant to all of us. Okay, next slide. So just to say that the guide was published at Men's Minds Matter, which is a community interest company that is dedicated to the prevention of suicide in men. The reason why we published it here is because it's a public-facing organisation. The guide itself isn't just for men, it's relevant to men and women, but our organisation speaks directly to men, so it does come. We do target that population, and it's available for download. And we think that it's relevant for our service users and stuff in home treatment teams. So please do take a look. Okay, thanks very much. Pranveer, you may need to unmute your mic.
Yeah,
that's it.
Okay, thank you, Luke and Gabriella. Unfortunately, we still haven't been able to get Sean Boyle and his team live. Can we go to the first slide, number 6 slide, which Sean has sent to us and he wanted to speak about? Yeah, thank you. It's I think looking at the slide, one of the thing to understand here is we wanted to highlight the importance of how the crisis teams and home treatment teams are integrated into the acute care pathway and how they interact with all other services. As you can see on this slide, this is an example of a newly, I would say, an implemented model in response to the new NHS England direction. As you can see here that the mental health service has an access to 111 service, and then there is a crisis response function and further home treatment function and interfaces with inpatient admission, GPs, existing teams, mental health services, IAPT services and local authorities, mental health acts. So it's really important that we keep
4479798553332.
We keep our services running effectively as safe as possible. Yeah, I think we will come back to it if we have any opportunity for Sean to get back to us and join us. But for now, we'll go to the question and answer session then. And I would be reading the first question here, which comes about when team meetings are supported by an agreed prompt checklist in support of decision making, this can minimize the risks associated with move to another modality, such as through Teams or other VC functionality. Is this something that you have considered to ensure quality of discussion is supported with any move to virtual team meetings? I can speak about my team and I would then pass on to other presenters. Within my team, we use an approach known as SBAR, which is we talk about the situation, background, assessment, risks, and recommendations, and we follow that up. It ensures that the discussions remain focused and to the point, and it is really helpful. We have been doing that face-to-face as well in usual circumstances, and now as well we continue to rely our discussions on that basis. If anyone would have another further ideas from the presenters, could people give an indication if someone else would like to add on anything else to the question number 1? No. Okay, if you have a link to the second question is if you have a link to video calling product name website, it will be helpful. Yes, I think that has already been mentioned there. And we have got a comment and question. At Northwick Park Hospital, we are taking the opportunity to ensure robust training and supervision in suicide response and safety planning. Has anyone introduced structured suicide/self-harm interventions such as SafeTel, distress brief intervention, or connecting with people? How well does this work in practice? Can I ask Luke to respond to this? Luke and Gabriella, would you like to add anything about the structured suicide self-harm interventions such as SafeTel, and how is it working in practice if you have these in your teams?
Sure, we don't use those models, but we do use a model that we've developed for our home treatment team settings. So there are some references in the slides, so it might be worth having a look at those. All of the work that we do in the home treatment team in terms of our psychological approach is focused on helping resolve crises and helping people to navigate crises in the safest possible way to get the best possible outcomes at the end of those crises. That doesn't mean that people won't be affected by difficult times or that people won't lose, but it's about helping people to navigate and to safely kind of see their way through what is quite unpredictable and also what is quite threatening. The handout the guide that we've produced covers really quite a lot of that model in quite easily understandable format. But if people want more detail, then I'd be happy to share the papers that we've written so far on the model that we use, and so if people want to get in contact with me directly, I'm happy to send those papers over. I am aware of connecting with people would be the only one that I have sort of had some knowledge of, and they do some really great work around suicide prevention, and they're a public health facing organisation about helping people learn suicide prevention skills, ways of communicating with people that are in distress, and that's for the sort of general public. It's about skilling people up in being able to have those difficult discussions. There's also information on the Men's Minds Matter website that has guides on helping people that are suicidal, but also advice for people that might be having suicidal thoughts. So again, they're things that have been produced and have been informed by the model that we use in the home treatment team in Lambeth.
Thank you. Next question, have you had to anticipate increased capacity for your service on account of increased risk and more frequent acute presentations arising from suspension of some elective outpatient mental health services as a result of pandemic? When the pandemic commenced, I think about some time ago, we noticed when the lockdown was put in place that there was some decrease in the demand for the crisis home treatment services. But over the last few days, we have again seen in my area an increase in people asking for home treatment. The further complexities are there because we have got some staff who are self-isolating and some staff working from home. So we've got less than the usual staffing levels we have at the moment. The other services in our area, the community mental health team is working as well, and we have had referrals from them, but we have seen some decrease from GPs. Kapil, is that something you would like to add on? How it is in your area?
I think it is similar. We have seen some reduction in demand. We have seen a reduction in the number of referrals from GP services. Routine or more elective appointments have reduced, and that is not just on the part of mental health services. The services have not reduced as much, but people are choosing to stay away from the health services as well. Equally, we are seeing when patients are presenting, they are presenting in a much more severe state. So there is some evidence that people are choosing to stay away from health services and mental health services as well, which I can see from the commentaries, which I think we have not successfully translated the message that the services are still open. We have changed our practices, but we are still operating. The mental health services are still operating. Services have moved towards more video consultations, but overall we are seeing a decrease across all crisis teams as well, our community mental health teams as well.
Thank you. Does anyone, next question is about, does anyone have any reflections on the utility, focus, or impact of public messaging, communications activity in respect of the pandemic on mental health and well-being? It may be that some of the messages about the NHS is still open for you has not readily translated to responsiveness of mental health services in the same way as with other services. Anyone who would like to, anyone like to respond to this question? I think just Kapil touched a little bit on it and said that, you know, the services are still open and our mental health patients are still accessing the services, and we are continuously adapting our services to their needs. So it is, you know, it is for us as a crisis service really important that we continue to respond promptly and ensure that we manage the risk appropriately. Next question is about just reflecting on the possible benefits of home treatment team expertise and learning being shared with other teams who are having to plan for and deliver more of their usual work as people are confined to their homes. Luke, would you like to comment on that?
Yeah, hi Pranveer, thanks. I think our crisis teams have great potential to do great things, given that we have been dealing with people in crisis, and our core task is helping people to safely navigate and move through crises. Partly why we wanted to produce the booklet that we did, which felt that doing the home treatment teams has so much relevance out there for everybody right now, that we are all by definition in crisis, as I mentioned. So again, it's how do we kind of offer that in new ways where people are able to kind of access information that could be of use to them. The internet provides a wonderful way of doing that. Our online consultations, in my experience, have been really beneficial and useful today. They seem to be very effective ways of reaching people who aren't able to reach us at this point in time. I think people are maybe thinking quite creatively about how they can make their services more accessible. I think many people will be very fearful about going to A&E departments at this point in time. One of the initiatives within South London and Maudsley NHS Trust at the moment has been to set up an A&E in the outpatients department at the Maudsley Hospital in order to divert people away from A&E services, so to free up those spaces to deal with COVID patients. So that's taking people out of that setting and creating something elsewhere, and that's something that has had to sort of happen quite quickly, and sort of has been something actioned by people working very hard to try and think creatively about different solutions at this point in time. So thanks for setting up this forum, because it's forums like this where we're able to begin to sort of share the work that we're doing and to make it accessible to more people in the best way possible. So I don't think we have the answers. These are unprecedented times. We can just do our best to think creatively and to try to have an impact in the biggest possible way. I suspect that as time goes by, as people move out the initial phase of a crisis, with all those heightened emotions, that we may well kind of see these more sort of depressive states coming in, and maybe that's when we might see more demand on our services, when the dust begins to settle a little bit, as the impact begins to have great far-reaching consequences for people. That there will be many people affected by this crisis, directly and indirectly, and it's going to bring a lot of challenges for people. And I think we are in a key position as crisis services within the mental health setting to really sort of have a key role here in supporting everybody, really. So for me, it's about how do we take that specialist knowledge and make it sort of accessible in the broadest possible way. Don't know, but we can think about that together.
Yeah.
Thanks.
Okay. Great. Right. Thank you. Yeah. So I think, I can't see any more questions at the moment. So if there are further questions in response to the webinar, these can be posted to the HTAS chat, and we will get back to you. We'll get back to you on HTAS chat. I'd just like to then summarize that today's session. I hope that everyone has found it of use. And in summary, the key messages for me to take home today are that, firstly, we should ensure that people continue to have access to crisis and home treatment services. We should keep risk management at the forefront of our services, and agree a way of working within the wider mental health system as far as possible, and with primary care systems as required. We must work as a team in these difficult circumstances, where we are being asked to make exceptionally sometimes difficult and challenging decisions in light of the pandemic. We should continue to prioritize the need of our patients. We should adapt to leadership styles as appropriate. We must make the use of digital technology to provide advice and support to patients wherever possible. We must make use of national guidance and be prepared to justify our decisions. It leaves me now to thank everyone, all the presenters who joined today, for their time and for their preparation. I would also like to thank the HTAS team, Cassie there and Eve, who have managed the session well, and to make this session practically happen. I wish that everyone stays safe and keep their patients safe. Thank you again for joining us.